Hello everyone, I'm Dr. Darsh Shah.
And I'm Dr. Altamash Raja.
And welcome to Medicine Redefined,
a podcast where we will explore the often overlooked but necessary components of health, what we consider to be the fundamentals.
We will investigate topics and practices that can give you and your patients the best chance to optimize a healthy lifestyle. It's time to move the needle forward and put the health back in healthcare.
All right, guys, welcome back to the show. Our guest today is Mario Novo. Mario returns to the show for part 2 of our discussion on blood flow restriction. In part 1, we discussed the origins, the development, and the mechanisms behind BFR. And now in part 2, we touch on the broad applications of blood flow restriction. Mario at first dives deeper into the molecular and physiological explanation of how BFR may influence protein and muscle metabolism. And then we switch gears and talk about the role of BFR with fractures, bone remodeling, and even in limb salvage programs. Mario does a great job giving us insight into how we can use BFR with our aerobic and resistance training programs, as well as using BFR to augment performance. And lastly, he talks about the differences between the various BFR systems on the market. Now, before we get started, do you know what can be an annoying process? Having to listen to ads in order to listen to podcasts. Do you know what's not an annoying process? Working locum tenens with the WeatherBy Healthcare. WeatherBy experts streamline everything from credentialing to housing with industry-leading technology and know-how so you can simply focus on what you love, practicing medicine. Head to financialresidency.com/weatherby to get started, and feel free to keep your podcast on while you're at it. Maybe a podcast like this one. Just a thought. All right, guys, I'd hate to keep this awesome discussion from you any more than I already have, so please enjoy part 2 of our discussion with Mario Novo. All right, guys, we're back with Mario Novo. Mario, welcome back to the show, man.
Hey, thanks for having me, guys. Pleasure.
Yeah, man, we're going to get right back into this. Last time you came on the show, we talked about, of course, the BFR, the origins of BFR, your beginnings and how you got started in, of course, the field, but also how you incorporated BFR into your practice. And what I really enjoyed is we had a mechanistic discussion of what the science shows and how it relates to what we're doing in the field of rehab, but also performance. And so today, I think we're going to talk a little bit more about the applications of it and how to incorporate it and how to do some programming. We touched a little bit on our exercise prescription, but let's dive a little bit deeper. So for those who actually haven't listened to the first episode, I would encourage you to just hit pause right now, go back and listen to that, because I think it's extremely important for us to understand that science, and then come right back and we'll be right here to pick that up. So, Mario, I think that probably the most robust evidence that we have is in the orthopedic literature, right? In the musculoskeletal medicine, I probably, as you mentioned in the previous episode, that's kind of where it started, right? Dr. Sato, he had realized that and was like, okay, this is really kind of working for that. So I think that's probably a good place to start. And of course, that's what you're doing primarily with musculoskeletal medicine. So I would love to kind of start on the continuum of rehab. So maybe, either we can use a kind of a case study where you have somebody with either rotator cuff pathology or ACL rehab kind of thing. How do you take a person who's recently injured, perhaps in the acute phase, maybe a little bit further, it doesn't necessarily have to be post-op, although I'd be interested to kind of hear your thoughts, both post-surgical and non-surgical management, and then take them through bridging that gap between rehab and performance. How do you kind of walk through that spectrum?
Okay, so first, I would say, listening to episode 1 will just lay down the foundation of a lot has been done in healthies. And that's really laid the groundwork out first for safety and efficacy, because as you know, we're not going to just willy-nilly try something, in rehab without some sort of shred of protection because of litigation. Right, liability is a big thing across the board, realistically speaking. So there's enough data on healthies, and as we roll now into rehab, where things have been looked at specifically, starting off with something orthopedic based, really was in the actual genesis of what started BFR to begin with in the first place here in the United States, and that's limb salvage. So you're talking about people that so the majority of this here in the United States starts in San Antonio Military Medical Center, SAMC, and it starts with attempting to find a way to augment muscle loss in all of these wounded soldiers that are coming back, right? This is, mind you, now we're post-Afghanistan war. It's an interesting place to be in time, and BFR is really a part of that war, much like with every single piece of technology that comes at our pleasure to dispose of. Tourniquets is something that its genesis is through war, right? It starts off as battlefield tourniquets to save its life or limb, right? So when we get to working with somebody in the field of rehab, the data really starts first with limb salvage and shows us that we can take individuals that are unable to really participate in much physical activity. We can at least slow down the rate of muscle loss. Mm-hmm. And we can do this through a number of inflate and deflate rounds that stimulate a mechanism that is associated with the increase in mTOR, which is, again, this targeted protein kinase pathway that leads to the development of muscle tissue, right? It's what literally triggers and turns on the process to use amino acids, to use whatever anabolic hormones may be associated with that particular period of time, because health and age, these things change, and we maintain muscle sometimes, let's say a similar way, but it still changes over time. So let's start off kind of there. You were mentioning there's a lot in the injured population, mm-hmm. But again, when we kind of start here from limb salvage, I think it's a good place because it'll allow me to kind of cover everything from there forward. So as I was mentioning, these individuals generally cannot do a lot, and the real risk of not helping them to return back to a high level of function is it can lead to substance abuse, obviously chronicity of pain, comorbidities, death, and yes, suicide associated with it. So the military had a big kind of goal to try to achieve with this group, and that's what greenlit a lot of the early research that allowed us to start having some conversations about, do we do rehab without or with BFR in particular situations when individuals cannot undergo much physical activity, and or are in need of even making the actual amputation and now having a rehab to a prosthetic device. So what the literature showed us was that we can slow down muscle mass, like I mentioned. We might be able to increase low levels of strength, increase a return back to function, measured with like a timed up and go, a sit to stand test, an actual strength test, whether it be a manual strength test or a dynamometer, looking at force and pounds and newtons. And that's what really kind of began the process of blood flow restriction making its way into medicine. It showed us that it was safe to use, that all of the previous research in tourniquets was applying in this field as well, that the individual is going to be underneath pressure relatively low, considering pressures required for surgery and pressures required for austere, literally life-saving scenarios. And that the time duration that they would be under would be quite low. So the protocols that were first used in this particular area start off with something we discussed last time, which is like ischemic preconditioning, which is a method that's used pre-surgery to improve survivability of that individual via increasing blood flow to the heart, blood flow to the organs, improving mitochondrial function, and decreasing like metabolic stress, like decreased inflammation. So all that stuff was there, and they go, let's just apply it. And the protocol that was used is essentially 5 rounds of 5 minutes, where the individuals put out what we call like a super hypoxia, a maximal hypoxic level. Like we find out where the systolic blood pressure is, and we cut that off, and then we go even above that to ensure that there's no blood flow happening in there. And that would be held for 5 minutes, and then it would be deflated for 3 minutes and repeated again, 5 minutes on, 3 minutes off, 5 minutes on, 3 minutes off. And again, what they noticed was that there was an increase in mTOR, but it was occurring via a mechanism known as cell swelling, or what Arnold Schwarzenegger said was the pump. Like Arnie was like on the money when it came to this.
Ahead of his time, man. Ahead of his time.
In a lot of ways, and I think it's because he was so engaged with his body. I mean, if you really kind of think about it, at an organism level, like here's this conscious who is using reps over and over and over. And he starts to really connect in some like profound ways that I think he obviously had a platform too to express himself. Different era, whole other conversation. Good one though. But
yeah, maybe for next time.
So Arnie was right. The pump had a mechanism that could also improve, hypertrophy, muscle growth. So the mechanism worked, in short, via an increase in a shift of plasma, so interstitial fluid pushing itself from the interstitium into the actual muscle tissue. So muscle, yes, has a semi-permeable state that can increase and decrease some sort of plasma level. And with this process happening, much like a red blood cell would increase in fluid, in these like hyperhidrosis states where there's that classic story of the lady drinking gallons upon gallons of water to win her son, I think it was a GameCube out of all consoles, and dies due to having too much hydration in her system and causing for red blood cells to essentially engorge themselves and burst, right? So muscle cells undergo a similar mechanism. All this plasma shifts in during these 5 minutes of hypoxia because, mind you, arterial flow is now stopped, venous flow is stopped, and it's kind of like the tissue is just in a state where it's got to, the cells in there have to make some sort of determination. So what do they start to do? They start to dilate. And as they dilate, fluid just starts to move in different places. And it appears that then when you deflate and all this fresh blood flow comes back in, there's already this inflammation mechanism that's been started. So every round that you do it, it gets more and more engorged. And then it seems to have this like pressure effect. Whereas as the literal muscle cell, mind you, your muscles are multinucleated. So there's many of these nuclei. And these little nuclei are getting expanded. And as they get expanded, they trigger a mechanism that kind of works on like the MAPK level. And what it does, again, in short, and I'm not a complete whiz on this because there's a lot of steps, guys. And I'm just a physical therapist.
Oh, stop it.
Yeah, I tease out. I'm like, I know those, and I'll come back out. Interleukin 6. Okay, cool. I know that one.
Buzzwords. That's what we're going for.
Yeah. So it has a mechanism that can have things like epinephrine and a few other mediators that in the end trigger mTOR. And so you get this stimulation to say we've got to adapt. Like that's all it is it's a really metabolic stimulus to have adaptation. And it seems, again, muscle is this amazingly adaptive organ. I can't stress that enough, how many times people need to be reminded muscles are organs. Look how many there are. And they're all functioning in this very intricate way that requires that we simply just move around, explore the world, enjoy it, and eat, and don't be completely lazy. And obviously take care of yourself. If this is one of those things that we have to say from our position of the globe, I get fizzy water in a can, put these things into perspective. But anyways, they're amazing. We use them for survival and benefit. So that starts off the conversation. There are situations in rehab where individuals cannot do much of anything. And it shows that there could be a way to augment, the amount of muscle loss during these periods of time where weight bearing are going to be very difficult, if not completely contraindicated. So that's also been used in ACL studies, where a very, very kind of prominent study back in, it was like 2005, where they took a bunch of individuals that had ACL injuries and just had them undergo regular rehabilitation. Because remember, when you do these studies in humans that are injured, there's a difference with simulated pain and real pain. Simulated pain, those studies, they get undergone through an IRB and a whole process, right? When it's real people being treated, everybody has to still receive treatment, right? And then essentially the independent variable is that extra thing you're adding. So this extra thing they added to this general ACL rehab was, I think it was twice a day for 5 days, that 5 minutes on, 3 minutes off for 5 sets. And what they saw was that those groups had less muscle loss. We can talk about that in a moment, because that's why mTOR is kind of so important, is to talk about how it offsets muscle loss. But they had less muscle loss in their quad, in their hamstring, and I don't know if they measured their calf. They measured 2 muscles, I think. Oh, the adductor, pardon me, and the adductor. I think that was the third one. And it was a calf. Sorry, guys. There's a lot of studies, but it was a calf. So what they saw was that, these ACL groups had a lot less muscle loss. They still had some, but a lot less. They equally had a faster turnaround for force production via an isokinetic device, like a seated biodex. These are devices that you push against them, and they, in a sense, it's a dynamometer, and they're designed to move with you. So you can test like eccentric strength, you can test max concentric strength and isometric. So you get, maximal velocity contraction, all the other things below. So they test them out, and the BFR groups almost lost no actual strength. Although they lost muscle mass, they didn't lose strength. And that was an interesting one because that talks about motor units and how motor units are, we know when we're in pain, both simulated pain and real pain, motor unit recruitment drops. And to this day, we're kind of still scratching our heads like, how are we able to still maintain force production while we're in pain? Like, what mechanism is causing that? Are we circumventing it? Is it endogenous opioids? Questions still come up in the air. But anyways, we see that these groups, they maintain strength. And the groups that just received regular ACL rehab, they really didn't. Now, mind you, this study has been replicated a few different times, with the replicated study showing similar benefits and other ones showing no benefit, no change at all. And I think it has to do with the cuff you're using. That always changes it. And it's not like there's one cuff better than another, but it simply just means that when you change the pressure, that changes everything, including your sample size. Like, where in their season were they at? How well conditioned were they? And then yada, yada, yada. It's all the intersubject stuff that happens that I think, which is why you see it and sometimes you don't. Mm-hmm. But we can say the mechanism is there. And the mechanism, what it does is it reverses what we can simply say is net protein balance. So let's kind of, in your mind, just think for a moment, okay, I got net protein balance, and there's an equation that equals the net protein, and that's muscle protein breakdown minus muscle protein synthesis minus muscle protein breakdown. So building minus breaking equals the net amount. Now, I think the first question most people ask is like, okay, so breaking, I get the building part. I got to eat protein, I got to move my body, and I build. So what happens with breaking? A lot of times the assumption is that when you're injured, there's an accelerated rate of breakdown. Mm-hmm. And that is not truthfully the case in all examples of an injury, right? That could be, let's say, rhabdo, right? That could be in the case of like inclusion body myositis. It could be in the case of some sort of bacteria in the muscle, or a direct muscle trauma right into it, some sort of like heavy contusion. But when you go out into, orthopedic land, like let's say an ACL, for example, we're talking about a couple body parts here. With the ACL, you're having something done like to the joint. So what ends up happening is that the muscle itself, realistically, every day goes through a breakdown process, just like our skeleton. So just like we have osteoclasts and osteoblasts in competition all day, right? You're also having this competition between mTOR, right? And then something that's basically called myostatin, right? So this thing called myostatin is part of, from my understanding, a family of other protein mediating, let's say, pathways. They're protein structures themselves. Okay, it's important to know that. But they have mediating pathways that they slow down the rate of synthetic buildup. And again, this just goes back to survival. You shouldn't always be on a state of building, and what you build might need have other resources elsewhere. It might need to be broken down and into its nitrogen constituents and used elsewhere. So this process always happens. So it looks like this. It's like a flowing like up and down. And when you kind of see like, oh, why did it go up? It usually goes up during periods of fasting, right? And what do we call it? Catabolism. Mm-hmm. So as a name, that's what that implies. So as that catabolic effect happens, when you eat, then it obviously starts to augment and come down. And then you have a reflective, right, wave, which is muscle building. So it's almost like there's an inverse relationship between this muscle protein synthesis and muscle protein breakdown, such that if they are even, what's your net protein balance? Neutral. You maintain muscle mass. So what they saw in these studies was that in a lot of cases, putting the tourniquet, creating the cell swelling, stressing the cell out, stressing the actual literal cytoplasm of the cell, and it undergoing this mTOR activation was done only because it offset the myostatin. It turned it off. And then when you look at the myostatin family, all the other things associated with it are things like scar tissue buildup too. And those are things that they saw also that, hey, maybe this could have some potential in these areas. And maybe that's even why we've seen some, again, these are just throwaway ideas that are happening in papers. These are just parts of discussions that I think still need a considerable amount of research in them. But they provide a framework to say, this may also have benefit in these other XYZ places where myostatin and mTOR have this anabolic, catabolic balance to one another. And again, like anything, it's homeostasis. So it's trying to find a way to regulate itself. And when you can't undergo with any exercise, what happens? The building also doesn't occur. So the breakdown that maintains itself becomes more prevalent, becomes the dominant of the two. And that's how you get a negative net protein balance. And that's what atrophy really is. It's the lack of stimulating mTOR. So this is where if you take a step back, you go, okay, what can I do then? Well, again, I can stimulate it with protein intake, because we know simply just ingesting amino acids, that's the specific, obviously, leucine, but in conjunction, all the essential amino acids appear to play a good role when they're all given to a patient in a bolus. And there's been studies that have literally looked at that, where they take patients pre-op and they tell them, twice a day you're going to have a protein bolus of whey protein, and then you're going to do that before surgery. And then we're going to go ahead and perform surgery. I'll find the study for you, but I believe that one was a total knee replacement. So they looked at the total knee leg and obviously the non-surgical leg, and they gave them protein. And what they basically saw was a group that had protein, guess what, lost less muscle and retained more strength, right? So even though we know that muscle size and strength in healthies aren't necessarily associated, like you can get bigger, not get stronger, or you can not get bigger and get stronger. Maybe when we're in pain, that's part of that mechanism, right? Maybe there's other things that are happening in that pain process that has to do with, again, when we think about motor unit recruitment, that's kind of where things get a little bit more interesting. Because now what you're talking about is there a way that when we have pain, we can still use other mechanisms, like not just the mechanoreceptor transmission, but metabororeceptor transmission. Like these are like these, type 3, type 4, or group 3, group 4 afferents that literally, when a muscle gets acidic, what does it do? It makes heart rate go up, and it makes type 2 motor units contract, right? So it increased. So that's like one of those proposed mechanisms. And they think that's why these patients, even though they didn't do any exercise, just having this thing increase on their leg, decrease, increase on their leg, decrease. Or pardon me, that we're still doing some rehab, because there is that factor. They were still doing some. That's maybe why they had that extra benefit, right? Because every time they took themselves into that hypoxic state, these metabororeceptors were conveying information for low-level recruitment somewhere in there. So if they were still able to retain recruitment, you maintain those muscle fibers that are associated with those motor units, and therefore less atrophy, right? And you're maybe holding on to the higher end ones as opposed to just the lower end ones. And even then, it just shows maybe you just lose less of the higher end ones. Because even if you can just stimulate them a little bit, that's probably better than nothing, right? So far, are we following?
Yeah. Just a quick follow-up on that, though, Mario.
Yes, please. Let's stop there. Put everybady's back in their head.
For that specific study that you're talking about for ACL rehab, I mean, I imagine you alluded to kind of how we make nutritional adjustments when athletes are injured or just individuals are kind of going through some type of dysfunction or pathology. And if people go way back in the archives, Dr. Arndt was on here talking about how, athletes, when they are injured, they tend to eat a lot less. And again, you kind of talked about this catabolic state and preventing disuse atrophy, and your body actually still needs more energy, not quite to the extent where you are when you're training, obviously. But, you kind of already explained that. My question for you is, in that paper, I imagine all the nutrition, everything is controlled for, or are they also looking at those types of variables? And if so, then the question becomes, how do we tease out if BFR itself is the true thing that's causing the effect?
That's a good question. And that is a limitation in those studies. That's why when you look at the majority of any orthopedic study across the board, many of them don't have things like that controlled, because you're dealing with real human subjects that you can only really have so much, kind of signing over of their rights to be like, I will participate in this study for X weeks. And then you also introduce a lot of other things that happen with patients, allergies, specific diets, comorbidities. So it gets complicated to tease it out. That's why we look at the healthies, and you go, okay, what if I take a group of healthy people and I do control what they eat and I do control their protein intake? Then you start to see, it does have an isolated effect, but it may be a little bit less sometimes in the healthies. And we think that's just because they're starting off at a higher level, and it may require more stimulus to make things happen. I don't know how more specifically to say that we just need more research in it. but we can at least say it's safe to use. And the groups that it has been used in, again, across all the studies, does show that there is some effect. So if we then kind of extrapolate that and say, if we have an option that's safe to use in the benefit of this patient, and we combine it as we usually do in clinical care, we always combine things. That's kind of the reality of where we live in. We can say we're not adhered to a specific one single protocol, right? We are allowed to practice within our licenses and say, let's try a couple different strategies at different levels. Some of these are maybe behavioral strategies. Some of these are maybe pharmacological strategies. Some of these might be physical strategies. I live in the physical world, and then I provide education on like, hey, when people are healthy and they exercise, they generally do consume a little bit more protein. And safe proteins to consume are X, Y, Z. There's new data now suggesting that red meat is likely a causality for certain types of cancer. So, if I've got somebody coming in who's a little older, I might say, hey, here's a study, look at that. That's generally what I do in clinical care. I pass things that undergo a process of screening and then provide it to the patient and say, hey, here's some things to consider to have the best outcome. But I would generally say the mechanisms show that there is a foundation for this process. But mind you, this is like low level, just inflating, deflating. Again, I would say in the healthies, it also shows that there may be a slight benefit in some aerobic sports, namely like cycling or running. Because what you're doing, like in pre-ischemic conditioning, is you're increasing, right, more blood flow to the heart, right, to coronary flow. You're increasing more oxygen and blood flow to where? The kidneys. And that's what we're always trying to protect patients from the hospital. So in healthy people, shows there may be some improved physical function. And then the mitochondrial improvement as well. Like they undergo more mitochondrial biogenesis. So pre-surgical and in healthies. So there is some data there to suggest we might be getting some additional benefit with this if it's safe for the patient. But you have to think realistically, it's 5 rounds of 5 minutes on.
For those types of protocols, Mario, with the ischemic preconditioning, is it just 2 limbs that are being occluded and kind of released with the blood pressure, or, with the BFR, or is it all 4?
For the ischemic preconditioning, I've read the studies that are on the legs, but I know it can be done on the arm as well.
Okay. But you never want to kind of do all 4 limbs at the same time, from what I understand. Is that correct?
I've not come across anything that would suggest safety in doing so. Even in the pre-ischemic conditioning scenario, it's typically going to be from the lower extremities or from the upper extremities, but not all 4.
And then in terms of, you kind of alluded to just increasing preload, which will, convey a lot of those cardiovascular benefits. Is that typically when you're deflating the cuffs, that's when you're getting it? Because when you're occluding,
correct,
you're not getting that. You're almost
you're actually getting reduced.
Yeah, exactly.
You're actually getting reduced, which is why heart rate goes up.
Right.
Yeah.
Okay. So that kind of, I think that's a good segue into maybe what about for individuals? I know that there's some literature kind of looking at it, obviously cardiovascular disease is the #1 killer in this country for sure. Right. So what about individuals who might have coronary artery disease? There's some stuff I think that they looked at individuals with heart failure, that kind of stuff. Would this be a contraindication, or if not, then how can you incorporate that into practice?
It could be a contraindication when you factor in and compound anything within the peripheral arterial system that has dysfunction. So if there is a PAD, a peripheral arterial disease state going on, whether that be diabetic, whether that be lymphatic associated, or whether that actually be, simply just having atherosclerosis or a history of smoking, right? Those are all things that you're like, nah, the plumbing is bad, right? You want to think of it like simple, like, okay, if I do this thing, it's going to help the pump. Why would it help the pump? Well, there's less preload. So in that scenario, there's less stress to the heart to begin with. And the heart is a muscle and it does need to undergo some exercise. So what if I let it increase some heart rate, but without as much arterial stretch? So it's not as much actual, and mind you, those tissues, they get damaged. So we know placing the heart under less stress can be beneficial. So in those studies, that was kind of the thought process, right? And then obviously once they deflate, more blood flow comes back, you're increasing preload. That seems to improve factors with, MAP, mean arterial pressure. Seems to reduce effects of things like orthostatic hypotension, right? Improve standing blood pressure, tolerance, increase in function. Again, whether that be like walking down the hall. I don't know if there's a faster discharge rate from the hospital. I've not looked further into that topic, but it has been used for those situations where it is safe to perform, where there's no arterial issues going on. And even with the arterial issues, it kind of, again, like you start going down like the levels, like, again, where on a physician standpoint do you want to be at with that? Do you want to assume the risk or not? If there's varicosities, might you blow one while you're doing this? Might that increase chance for clotting? And then you go down that level, like, are they, what medications are they on? So I think when you're in the hospital setting, it's a lot more iffy. Once you get out of the hospital setting and patient has been discharged for outpatient physical therapy, and they've undergone, a recent echo, they've undergone maybe a recent calcium score, and things look good, and the doc says you're ready to do some exercise, definitely can be very beneficial for those exact reasons. You're reducing preload, you're helping to increase heart rate, and you're doing it with lower level activities, right, that would otherwise require a higher barrier of entry. So I can get benefits that have been seen with things at like 40% of heart rate reserve for like 15, 20 minutes that would otherwise maybe take me double that amount of time at that same heart rate reserve rate to have adaptations regarding, improvement in mitochondria, improvement in VO2, improvement in, what was another variable they've looked at? I think they were looking at resting heart rate and blood pressure, but also just tolerance, like just tolerance to walking, tolerance to physical activity subjectively. So if I can go up from that level, if I've got somebody who's safe to perform this with, and then there's a couple applications. It could be applied with a bike. There's studies on that. Applied with a treadmill. Applied in the water, aquatics. That's been done with things like osteopenia, osteoporosis, fibromyalgia, and low back pain in women mostly, but they've had some men. And then, so what you basically get from those studies is that shows us aerobic conditioning with blood flow restriction can be a benefit to the heart itself, measured via our typical, routine measurements of cardiovascular capacity and cardiovascular function in the injured population that are safe to perform it, of which does include individuals that do have, a past history of cardiovascular disease. But again, you have to kind of like go down the line and find, is this a safe person realistically? Because the studies enroll people and, participants, they sign away their risk like they do also with us, patients sign consent, but I think you still have to be, I'm always very careful. I've been doing this for a while. And, I've had healthy people, all right, I had a physician put this thing on his leg and like scream the dickens. Like, oh, my sciatic nerve pain. I'm like, what? Dude was sitting in a really odd way on a bike. And I mean, he lost his mind. I've had a couple people like, just get vasovagal on me. I had a guy the other day, I put it on both his arms. How to be a strong dude, put it on his arms. And the guy's like just sitting there. He's like, oh man, I think I'm getting dizzy. And I'm just like, whoa, what is happening? So, you have to be careful when you do it. But I've applied it in the way that the studies have suggested. So I've had patients with OA combined with hypertension controlled, high blood, on some sort of pathomimetic drug, something that's either a calcium channel blocker and a combination of just different other diabetes. I would say is when you got to be really careful with. Just because of the pressure you're applying on, the fact that there's already neuropathy down there, likely because of a considered amount of vasoconstriction, so just poor arterial health, in general. Because the studies on improving arterial health aren't really all that great in BFR. So, that's just a reality. So I just avoid those and I try other techniques. But in those cases, I've had good benefit of patients basically saying, my legs are getting a heck of a lot stronger. I'm walking further, I'm standing more often. And in general, they just feel like they are making some progress because, again, the mechanisms in the healthy studies and the mechanisms in these, again, injured populations that we've seen do suggest that there are safe benefits that we can achieve, to again, heart rate, blood pressure, VO2, and then all the other functional ways that we measure cardiovascular capacity. 2-minute walk test, 6-minute walk test, timed up and go, and then just cardiovascular stress test. Yeah. So yeah, I think where you're going, which is actually a really good kind of segue, I'll add myself, and then you can go with this, is that we just went from like not doing anything, almost being like bed rest. And this is where, if you want to have the talk of fractures, that's also another good place that we can think about maybe more realistically, that those 5 minutes of high pressure and release really do make some better benefit. And that has to do with hypoxic factor. Wait, hold on. HIF1A, hypoxic inducible factor 1 alpha. Yeah,
it's a mouthful.
It's a mouthful. So I think where you're going, we went from like limb salvage, these people aren't doing much of anything, to now, hey, cardiovascular patients, they're doing aerobic exercise. And really the next thing is then resistance training with BFR. So if you want, I'll just end there, and then I'll just kind of talk maybe about some odd things like bone healing, which is probably a really profound one to hit on.
I'd love that. What I will say, I do remember coming across a systematic review. I think Johnny Owens actually was on that paper. I don't think he was the first author. Yeah. I think this was a couple of years ago in one of the orthopedics journal, but they looked at whether or not hypertension, if it had a significant effect adversely, at least. I mean,
right.
Obviously we talked a lot about that. It's increasing pressures. And in this paper, I think they had maybe 5 or 6 studies. The end that they had was less than 100. So it's not really, we don't have a lot of data on it, but at least in that review, they had showed that really you don't have significant adverse effects, and it is a safe modality to use. Yeah. But again, I go back to the data it's meager at best.
Yeah. Weightlifting definitely has a stronger effect on things like heart rate and blood pressure by a lot. That I think that's where, again, you always you look at it as a tool, right? It's not something that applies in all scenarios, but it can have some particular, applications when all things are considered. Because again, you go back to the mechanisms and you go, okay, what has BFR done for us in medicine? It's provided for us, I think, a review of these mechanisms through a way that can be augmented, from the external. Like, it's something that we can do. So we're kind of in control of pulling the levers, how much pressure, how much time with what, with exercise, without exercise, what kind of exercise, with neuromuscular or no neuromuscular stim, with protein, without protein. We can like pull these levers and we can think, how do we create a system? Again, this is how I practice, obviously in an evidence-led way. That's just kind of giving me always ideas, and that's what BFR has really done for me, is it's opened up a lot more ideas on what is the true role of exercise, in these painful, deconditioned, impaired states. What the heck? Why do we pick exercise? Again, I always come back to that. Why do we pick exercise? Because patients always kind of scratch their head. A lot of people, especially here in Tennessee, are like, oh, treatment comes in a bottle. They're just of that generation, that biomedical generation. Treatment comes in a bottle, or you go to the chiropractor and he just slams you around the bed and tells you you're all out of whack. But it's like, you want me to do exercise? Like, I avoid this. I sit on the couch for a reason. I don't like going to the gym. So when you now kind of, we're just from a different generation. We just truthfully are. We're thinking about this, I think, a lot more as we naturally should be, because the proverbial crap has hit the fan. It's really expensive now, and not a lot of people can all afford it. So we don't have time for low level treatment. We need high value treatment. That's the only thing we can aim for.
The irony in that situation, Mario, is the geriatric population could arguably benefit the most after in the rehab realm.
They
right?
do.
And you talked about that last time.
Yeah, there's great studies on that.
Yeah. Those are the people that it seems to be most challenging with.
Yeah, there's studies that look at elderly men and women mixed with things like, I think it was a 6-week, an 8-week, and a 12-week study. And each of those looked at training. It's like open chain, like bicep curl, knee extension. I think one of them maybe had like a hamstring curl in there. And what they saw was, like, as they just went through time measuring these people, the ones that did BFR, they got stronger. I don't recall if they measured cross-sectional areas specifically in these studies for hypertrophy, because you can kind of get in the weeds with that, but they saw them get stronger. And then over the course of deconditioning, the same rate. You're going to train for 6 weeks, 8 and 12, and then we're going to decondition you the same. Groups that did BFR had a lot less loss at all. And then once they even detrained them out to 24 weeks, the 12-week subject groups still held on to some strength compared to the control groups that, were doing the same low-level exercises without BFR. So you kind of like start thinking about, this isn't just on the patient level. This seems like a very interesting tool to apply in just the concept of, human beings in general, having another option for exercise, like just another category. That's it. Just another option for exercise when things get bad, when your joints cannot take load, when your heart can't handle high pressures really placed on it. Could it be an option for you? Yeah, it could be, totally. And then you just go down from there, like we were talking about, somebody with a fracture, again, for example, to just touch on this and leave it. Your bones don't just get stimulated with compound, compressive movements on them. We've learned this now because of BFR, right? It showed us that when you provide a tourniquet around a limb, there's also this interstitial fluid pressure between the periosteum and endosteum of the bone that increases. And that pressure similarly has a mechanism that stimulates osteoblastic activity, much like the pressure stimulates mTOR, much like the pressure stimulates, again, augmentations in blood pressure. So it's just one of these pressure gradients that, again, nature has provided. I think it's like a fundamental mechanism when we do look at physics, and then you kind of go backwards from there as an organism, as a species evolving on planet Earth. Why do we have those? And it's like, because that's all that there's around to make. Like, why do we all have vestibular systems that use fluid to orient gravity? It seems like that's the easiest distance between these 2 points to make evolutionarily. So yeah, when you put a tourniquet on, you know what it stimulates? A muscle contracting around a bone. So it's not just a combination of the bone being compressed by gravity and that's stimulating osteoblast. It's also the compressive force of muscle. And it shows that when that happens, right, blood flow gets reduced. A hypoxic environment is created. And then you stimulate something called HIF-1A, hypoxic inducible factor 1 alpha, from the bone. And that is a process of then further increasing VEGF, vascular endothelial growth factor, more blood flow to the bone, increasing bone phosphate uptake. It appears that you also stimulate receptors that now kind of open and say, hey, we're ready to receive, more of this material, including of which, if there is exercise performed with it, and it kind of gets a little back and forth in some of the research, like how often does it always happen and what level of exercise, like super high level seems to be what we need. But growth hormone, right, seems to be a byproduct of stimulating the pituitary gland with high levels of lactic acid, which happens when you perform exercise with BFR, right? Whether that be isometrics or whether that be an open chain or closed chain exercise. And you can go up from there. If the patient can't do weight bearing, can they do isometrics or open chain? If they can't do open chain because of where the fracture is at, and it may be a contraindication for them to move the joint, so they're in a cast, it's immobilizing the joint. Can we maybe just do then, isometrics, or let's say out of the cast? Because there's been kind of a debate. Can we put it with a cast? Can we put it without a cast? As the limb undergoes cell swelling, might that create a risk, on the limb, in the actual cast itself? So I think that kind of goes back and forth, but you can kind of see the different layers that it can be applied, clinically. And what does it do? Again, it improves the ability for that bone to continue to maintain a strong matrix and to continue to have adaptation. So again, what do you have? You just have a faster return to function. And that's kind of, to end that topic, that's, I think, the last thing you'll get from just doing it without, heavier types of exercise. But that's, again, one of these other little side rants, I think, that goes on to just provide another option for why we should use it, again, with good debate. There should always be a healthy debate in this topic. I'm never one of these people that's just like, it's all or nothing. It's like, I'm just telling you one side of the coin. It shows to have these mechanistic effects. Does it always have that? I mean, that's science in general, right? It's hard to generalize always. The larger studies, I think, it shows us that, hey, if you could do it with exercise, you get this collagen benefit because of growth hormone. Like, I don't know, are you guys privy with that? How growth hormone is associated with collagen synthesis?
A little bit.
I think so, but I mean, yeah, I think it's worth kind of quickly touching on it if you want.
Yeah, go for it.
It's so simply, when we're injured, it shows that our body uses this myostatin pathway to shut off mTOR, which would otherwise dynamically continue this process of putting on more skeletal tissue, which just means more calories needed to sustain that tissue. So there's some sort of mechanism that says we're going to turn on the scar tissue pathway. And along with the scar tissue pathway, there seems to be an upstream stimulus to the anterior pituitary that says, I'm going to release growth hormone. And growth hormone, once it makes its way to the liver, it appears that if there is, in the dietary, in the environment, in the liver, due to the dietary intake of vitamin C, you can then have the synthesis of collagen. Does it always need vitamin C? I'm not sure. But to my best understanding, vitamin C ascorbic acid is associated with growth hormones kind of step into, promoting collagen synthesis, which is just different proteins that get stimulated that are not made from predominant essential amino acids, right? These are made from kind of like conditional amino acids and then just your common everyday amino acids that we make on our own. So why is that important? Because collagen is what we use to heal bones, what we use to heal tendons. So it's this ultrastructure, and it shows that exercise improves it. And it also shows that maybe BFR might be a mechanism to also have that process undergo as well. And that's kind of where the debate has been at in the BFR world has been, when we use it for like an example, an Achilles tendon repair, there's been a study on that looking, does BFR maybe have a faster turnaround with this? And it did. It showed that it had healthier healing to the tendon. Obviously, the individual was able to undergo, low levels of higher metabolic stimulus before their control groups, because as you know, an Achilles tendon repair is going to take, anywhere up to about like 8, if not sometimes longer, 12 weeks before that person might actually start being able to put and tolerate load because of the health of the tissue. If it's been a chronically injured tendon, it may take longer. They may want it to really scar down, before you start actually putting a lot of load through it. So, I think when you factor that in there, that ability to maybe have that, that in my department is really beneficial because I can't order up growth hormone in a syringe to inject a patient with. Yeah. And it does show studies in that, animal studies.
Not legally, but yeah.
Yeah. Horse serum.
Yeah, I mean, like you can literally look at like Sylvester Stallone, Arnold Schwarzenegger, Mickey Rooney, and a few of these other like Dolph Lundgren, I think was his name also, like all these 90s action heroes that all took growth hormone because they all thought this stuff was going to make them jacked. And all it did was make their facial structures get bigger because it stimulates more collagen and bone.
Right.
And there's
That's
this
Ivan Drago, right? You're talking about Ivan Drago there? Dolph Lundgren?
Yes. Yeah. Dolph Lundgren from Rocky, but also from Universal Soldier 1. If you've not seen that movie is the best, man.
That is a good one. I do agree.
Man, I used to like walk around, I remember in the 90s, like with, I think like a highlighter, like taped onto like a headband with a pair of like my dad's sunglasses and just being, like being in the backyard, like Universal Soldier. I was a kid, man.
That's Van Damme, right?
Yeah.
Yeah, it's Van Damme. Yeah, that's a good one.
Great movie, man. Great movie. The second one or the third one? Nah. The first one, yeah.
I agree.
Mario, I wanted to get into kind of practical uses now. Obviously, from everything you've been talking about in the last 2 episodes, BFR has a lot of upside, right? From rehab to performance to just the physiology that you're talking about. My brain's been blown, honestly. It's probably too much blood going in the brain. I need to cut it off a little bit.
Put a strap in there.
Strap around, that's right. Strap around the neck, right?
Break back down.
Don't do that to anyone listening. No. Don't put a strap around your neck. But with the high upside, right, comes some of these safety concerns, right? So for our listeners, how do they get started after hearing about all the benefits? Is this something that they need to go to a practitioner for? Is this something that they can just go on Google, type in BFR and buy some cuffs? How do you suggest our audience get started with this process?
So probably, I mean, if the audience is healthy and they're like, I want to use this in exercise, know that beyond the aerobic training, you've got a whole list of applications in resistance training. Studies showing open chain and closed chain exercises could be very beneficial. definitely exercises in a more upright position seem to be more safe than inverted positions, like an inverted leg press. That could actually has shown in the literature to have a high effect on just increased blood flow, to the heart and to the brain, and that could be kind of detrimental. So you're always thinking like at the horizontal, or vertical against gravity. But in all of those studies, it shows, in healthies. So, I mean, if you want to like finish off like all the injured populations, things like OA of the knee, ACL, patellofemoral, meniscal issues, Achilles repair, total knee, total hip. I think this is where you get into the proximal and distal studies. Anything distal seems to fare really well with it. Things that are more proximal are a bit more complicated. It shows that there may be some benefits systemically, just considering the anabolic environment. It may have some benefits with some pain, but it may not be largely like changing much of the strength and maybe muscle size the same way, because the blood pressure dynamics, right, are a bit different. But it can still have benefits, to hemostasis, reduce clot formation. That could be highly beneficial for somebody still, in a hip replacement scenario, in a shoulder replacement or rotator cuff scenario. But yeah, like for like a Tommy John surgery for wrist, very beneficial in those areas. Bicep repair, pec repair, again, that's more proximal, maybe not as beneficial there, but it does show that bench press, because the tricep, right, is an assisting muscle for the bench press. It can increase more pec demand, much like you can get more glute demand with, doing BFR for your legs, because your quads just tax out and so does your soleus. So you get more in the glutes that way. Gotcha. But trunk, not really much in the trunk. But somebody who wants to get started, know that there's a lot of data kind of covering this whole area. Meaning you can apply it on a weekly walk on the treadmill, on a ride on a recumbent bike is usually a bit more comfortable than an upright bike, just because of the way that the cuffs and the seat kind of hit you. Guys will have a harder time with that than girls will. And then, it depends on the kind of cuff, but, could they be used in the water? There's some that are waterproof that can be put in the water. They have one-way valves, so you can go in the water and water won't come back in. And those studies have actually been quite beneficial for showing, improvement in reduced reduced time to complete a certain yardage, swam the pool, including time and including lactate threshold. And that's what it's also shown, like riding a bike. It's shown that individuals have a higher lactate tolerance, a potential higher peak power or mean power. I actually got to do a study with the Titans that's actually what we saw. We never got to freaking publish it for some reasons, but it was a good case study that showed that, you could definitely get some really good benefit from doing this, in a preseason standpoint. So anyways, not belabor the point. You can apply it on those scenarios, and then you can apply it in a resistance training protocol, with the aerobic being like 4 to 5 days a week, and the resistance training protocol being somewhere between like 2 to 3 days a week. It can be applied, and that kind of makes sense in general, because you're kind of stimulating more the metabolic route, which means that you're not using, heavier weights to augment an increase in motor unit recruitment. With that heavier weight having an ability to generate more torque and a subsequent increase in type 2 muscle fiber recruitment. Right? With BFR, it's all metabolic. Right? So what you're doing is you're stimulating those type 3, type 4 afferents. They come up to the heart, increase heart rate. They come to the brain. They say fire more, and you get that process that happens. Are they equivocal in muscle protein synthesis? Some studies suggest yes, they can be. Much like studies suggest that low-level training taken to failure can have similar hypertrophic benefits as high-load training taken to failure, with the change in repetitions obviously being, the main difference between the two groups.
But Mario, with that metabolic, more of a metabolic demand, are you getting more of a type 1 recruitment as well? You
always recruit, no matter what. Yeah, so right. Type 1s are still recruiting even when you're doing high-load training. Because remember, Henneman's size principle,
right?
Just as to kind of cover it there, because there are a couple other scenarios where motor units can be recruited in different ways. But Henneman's size principle just tells us that there is a a size associated with it. So we always start from low, type 1, and then we always go with the larger ones, type 2. So that happens no matter what. So let's say if we're doing low load and high load, the high load, those guys all kick in, and then obviously the type 2s kick in. With low load, there's more of a buildup. You've got to ramp up to there, and it doesn't usually happen in the first set, which is why the protocol for BFR has so many repetitions in there. 30 reps to kind of set the stage metabolically, and then you've got 3 sets of 15 that appear to be like the working sets, where now there's a high level of motor unit recruitment because of the hypoxic environment. And also some of the other metaboreceptors that have the ability to tell the brain, fire, contract more.
So you mentioned that last time, again, the first set being 30 and then the subsequent 3 sets being 15. Do you ever veer off that? I mean, I know that's the convention protocol, but in which maybe you touched on a bunch of different pathological states that it's applicable in, is it more like, what's your thought process when you do veer off that 30, 15, 15 protocol? And like, when will you do it?
So let's say, again, audience of healthy people wanting to apply it to themselves, I would say it's just shoot for the research protocol as a baseline. Right. Like, for example, you should run yourself, like, let's say start this. You've agreed and you've said, you know what, I think I'm going to try this method. Maybe I'm getting a little bit older. Maybe my joints can't handle this heavy weight. I don't like to go running anymore. Or I just don't have the time, right? I want something that's maybe a little bit less time dependent, 15 minutes doing some cardio versus maybe 30, 45 minutes. Or you know what, there's some days of the week that I just can't get underneath the heavy weight and I want to do this. I'm giving you all kinds of scenarios, like listen.
Right. Yeah.
Or you're like, you know what, I like training. I like training heavy and I want to make sure I'm not going to leave anything behind on the floor. So those are all possible scenarios that you go, BFR will likely fit. And then the next things are, am I healthy enough to do it? And if you are, let's move on. So let's say you are, the first thing I would say is, try to first assess yourself. If you're going to apply BFR, spend about a couple weeks, trying to see, can you tolerate either the protocol alone without BFR? Like, let's say it's a body weight movement, like a push-up or a squat. Those crush people because no one really does, 75 something push-ups in a sitting in like 8, maybe 6 to 8 minutes. Some people might take longer to do that. You got to build up to it. So if you're like, I can't do push-ups, okay, do dumbbell chest press. Okay. Now with that, there are some studies that show you don't have to do a 1 repetition max test, because we can arguably say is pretty dangerous to do.
Yep.
I don't ever do a 1 rep max test unless I've got people around me, and I haven't done it in a number of years. But let's say, for example, I'm going to use a 10 rep max test, and there actually is, a mathematical way that you can go, just Google it, 10 rep max, estimated 1 rep max, and you'll see that there's a quantifiable measure. You get your 10 rep max, which your 10 with, you're like, obviously you should still have safety pins, whatever you're doing. And you get that number and you go, oh, here's my estimated 1 RM. So here's my training percentage for BFR. Set yourself up with that training percentage. And then the next thing is you have to assess your pressure. So buying cuffs is probably where that next topic comes in. So I generally tell people, I generally promote companies that I know you can just reach out and grab. Especially if you want to apply it to yourself. Again, kudos to you. You've done your homework. You think you're safe. Okay. I am not liable for you doing something for yourself. Please, let's all get that across. Well, I think you would agree.
No. Yeah, no, we definitely. Yeah, this is not medical advice. This is not any type of advice. You have to discuss it with your physician. So, but these are just hypothetically for academic purposes.
Yes. So what the literature shows is that you do this 10 rep max test, because that's how the studies do it. And then what you do from there is you set up your weight, and then again, applying pressure, the cuff system. So purchasing cuffs, I would say the gamut of cuffs that I've covered. And to throw it out there, yes, I do have an affiliation with one of the cuff companies now. It's another PT, been working together for a number of years. And he makes just good sound quality cuffs. That's all I can say. Out of all the cuffs I've tried, he's been open and receptive to things that we need in the clinic, like easy to clean, should be contour so that it always fits the limb as appropriate as possible. It requires less pressure if it's contour versus straight. It should be a good single bladder, so it doesn't have a multi-chamber system, which doesn't have really any evidence behind it. So a single bladder means that when you inflate it, it's kind of even pressure all the way around.
Yeah.
Should have an ability to like rapidly deflate. So like a deflate button that you press, not something that you maybe have to reconnect the gauge back to, because that can, again, it could take long, and you want to get it off if you need to get it off. And the next thing is you want something that's not too narrow. So his cuffs are kind of built based off of just what the literature showed us is safe. So that is an H+ cuff. You can go on Amazon and find them. And I think that if you wanted to, again, he gave me like a code, and just you tell me if you want me to plug it or not.
Yeah, go for it. I'm sure people would appreciate that.
Let me see here. So it is, I don't know why he made it my name, Mario 10.
And that gets him what?
And it just gives you 10% off on the cuffs.
Cool.
I think it's like on your total purchase. But anyways, like those are good cuffs to get. If you went down the list from there, I probably would say from those, you can probably come down to something like H+. I mean, pardon me, H+. Is it Fit Cuffs? Yeah, Fit Cuffs would be the next one. That one you do have to reconnect the gauge. But they do have a system that you plug it in, and there's an app on your phone, and it will figure out your pressure for you, which is kind of cool. The H+ ones, you don't. You're going to have to get a Doppler and check this out on your own. Or you just go and get your blood pressure taken from your leg or your arm, from somebody who knows how to assess blood pressure, like, from the popliteal fossa or from, radial. So, yeah. And then from there, the next ones I think you could buy outright on their own is maybe like Smart Tools. Maybe I think you can get them on your own.
You can.
And then I think if you go to computer systems, I mean, there is MatUp. They are in Europe, and if I can give you in the show notes like their contact information. But that's like a 2 system. It's like one screen with two plugins. Like if you go to my Instagram, like you'll see I've used that one in the past. It's a cool system, touch screen, like it automates everything. And then you have the Owens Recovery Science one, but that one you need to take his class. Like you can't buy Johnny's system without getting certified. Which, hey man, if you're really interested in BFR and you want to apply it to yourself, and you're maybe thinking about doing it in the clinic, I had for years, because I used to work for him, so I had for years like those cuff systems with me. And man, I trained with those all the damn time. Just made it easy. Just hit the start button. It detects you. You're ready to go.
Now, I think most people will agree that, the ones at least who are using this routinely, that's kind of the gold standard, right? The Delphi system is pretty much the gold standard. Of course, financially, it is much more of an investment. But again, I think that, if you're really doing it and I'm talking to, the healthcare practitioners who might be interested in this. And last time you talked about physical therapy, this is going to be a staple in just the education in the next 5 years, hopefully. Then you really want to make sure you're doing it the right way. And you want to be certified, you want to be educated, you want to be updated on the literature and know where it applies.
Yeah. I don't know if you can get CEUs, for it particularly, but you might. Yeah. I mean, if anything, also go to a conference, go to an orthopedic conference, invest the money. Obviously with COVID, I know this thing's annoying to be able to do that for all the right reasons, though. It just is what it is. But if there's one where they're speaking about it, that's a great opportunity, because you're likely going to get somebody I've been considering doing that myself, just kind of putting in a bid for a couple talks at orthopedic symposiums to have that talk with physicians to kind of like, let's scratch our heads a little bit and think about, PT plus this, like if you're already thinking rehab, okay, let's think rehab plus this. What does this give us? And why should we choose this?
Right. But what I would say that I think a lot of, at least in the orthopedic literature, physicians are up to date. I mean, I know one of the companies actually is founded by, I think he was a general surgeon, and now it's like, it also had exercise physiology. And his name is Jim Stray Gunnarsson. I forget what his company is called. Maybe Be Strong. I think so it is.
But that's an interesting concept by itself, because Be Strong, again, this is kind of where you get into that multi-chamber system. And Gunnarsson just went one way with it, and he was just like, we're going to design this cuff that even at a maximal pressure of 500 millimeters of mercury, which is where that actual gauge maxes out at, you're still not at 100% occlusion. Arterial, speaking on the area of the arterial system, still not at 100%. And it was like touted to be a safety mechanism. But none of the studies are doing that. The studies are using pressures that are a percentage of that maximal arterial pressure. And I think what his statement is, like, even at 500 on the gauge, it's still closer to like 220 in the cuff, versus the other cuffs that do have the ability to fully occlude you. Like,
what about the original Katsu system? Is that multi-chambered?
No, Katsu is single. Yeah, Katsu is a single band too.
Interesting.
You know, yeah, and that thing, the Katsu Master is what it's called. It's a pneumatic system. That thing takes you, the Katsu program takes you up to about 220, I think 250 millimeters of mercury, and they scale you up in percentages. So like you start at a low percentage, and like you progress percentages over time. And I think what that does is it's a fail-safe mechanism. It means you start off at levels that start to provide less stress, cardiovascularly speaking and metabolically speaking. And if somebody gets flagged for something dangerous, you're going to flag them in the process, so you stop
much earlier on, right?
Right. So I mean, I've always understood that. And then obviously, if you're able to achieve those maximal pressures, then you get the benefits that you generally do see with BFR, because there's no way around it. The pressures are just way up there, you know? So those are kind of like the cuffs, again, that you can get. And again, the thought would be, if you feel like you're safe and you want to apply it, again, 4 to 5 days a week on cardio, anywhere from 15 to 20 minutes. You could combine that around an exercise session where you are doing some weights. I did that for a number of years, where I might do that like early in the day, and then I'll give myself 4 hours, and then I'll actually just go have a training session, because it's such short period of time. Like, I literally would just set up my computer in front of my bike, or set up my computer in front of a treadmill. And if I had to do some notes that morning, or if I just wanted to catch up on podcasts, wake up a little earlier and do that, or listen to music, I would just walk on the treadmill and then go train weights later without it. And I did that for a while, and that helped tremendously I had some left knee meniscal pain, a pretty significant tear, and just unable to really run past a mile without pain. I can do everything else fine. But that was really a savior. And it kept on some quad size. Let me tell you, man.
Yeah.
Dude, walking uphill, like 3% grade at like a 2.5, 2.8, bro, it feels like you've got like a rucksack on you. Your quads are just like screaming. It's fantastic. I'm like, oh, I just got there.
Yeah.
And it didn't take long to get there. And
that's cell swelling,
There's much more than that, man, happening a lot. much more. But, that's how it could be applied. And I've had a number of friends of mine that, they cycle with it, on their off season, or as part of their training, as you're thinking about progressing into, higher peak levels. It's hard to sustain getting up there for a long period of time, because the amount of energy it takes to output on the bike, the wattage, and sure, you can increase the resistance, and that's a way to do it. But maybe your bike doesn't have resistance, or a couple other ways. It could be a tool that maybe helps in that regard.
Can I ask, Mario, is there a certain heart rate that you're trying to achieve when you're doing it aerobically? I mean, automatically the heart rate's going to go up, but is there a certain zone you want to be in?
If you're thinking of like danger zones, then you definitely should be assessing yourself for like your 85% of your heart rate reserve as kind of like a do not train mechanism, just like an early stopping point. If you've never done a cardiovascular stress test, don't be stupid here. Like, legit, don't be, because it'll kind of surprise you how quick your heart rate's going to go up when you do BFR with it. Because again, it's not even just what it's doing to you. Your anxiety is going to go up when it's your first time, especially if you're by yourself doing it. I remember when I was doing it to myself, I was like, what am I doing? I questioned it so many times, but each session I've always done with BFR is always kind of it's like a come to reality moment. Some people would say a come to Jesus moment, but I don't want to, I don't mean that in any way, shape, or form to be disrespectful. But that kind of situation where it's on you and you're like, what am I doing? What am I doing? Like, this hurts. Once you understand mechanisms, then you're like, that's why I'm doing it. That's why I'm doing it. And that self-talk kicks in. But and then the weight training, again, 2-3 days a week, it could be used in kind of a preseason kind of situation, or like, hey, I'm going to get back into doing some weights. So I might, do some weights without it. And again, I might have just included in another training session that week. As we know, for hypertrophy, it's best if you're training a muscle, 2 to 3 times a week similarly. Why? Because it's a smaller stimulus, recoverability is much greater. return to proper levels of motor unit recruitment and strength are there. And you want each exercise session to feel good, you know, and BFR, I'll be honest with you. I mean, you'll get bit by the bug for a little while when you first start it. And then, you know, I myself, I think the longest training routine I had with it was about close to like 16 weeks. And by the time I was done with it, I was done with it. Mm-hmm. I was like, I'm good. But man, let me tell you, like, just pause squats, pause deadlifts, deficit deadlifts, hip thrusters, overhead press, you know, like actually overhead press went up considerably just from building a strong base to be able to balance weight overhead. And I was probably the healthiest at that point coming off that 16-week that I had ever been really in all the other times, because I had multiple injuries and things that happened. And I really went at it kind of in that vein of let's apply the science, just like freaking, you know, the start of all this, you know.
Yeah.
I don't know why his name just eluded from me. The creator of blood flow restriction, Sato. Yes. Sorry. I have so many people's head names in my brain right now because I'm doing another paper. Sorry, everybody.
Yeah, no, it's all good. But Mario, this actually, you know, kind of leads to my follow-up question. So why is it that let's just say for aerobic exercise, if somebody's using it, not doing just regular walking on a treadmill, maybe they're doing cycling, right? Mm-hmm. You're still going through the action of knee flexion and contraction of the hamstrings and quads when you're going through knee extension, which is akin to doing bicep curls, right? It's just similar hinge joint.
It's like a light press on the way out, hamstring.
Sure, yeah. So the question is, you know, why is it that we can do 5 days, whereas for maybe bicep curls or tricep extensions or whatever it might be, the frequency has to be less to get the same effect? Why is that the case?
Muscle size, pennation angle, you know, tendon tolerance, the actual joint itself. You know, there's I mean, load bearing and non-load bearing structures make a big difference with it. Like, I challenge you to do an upper body, like a UBE, an upper body bike.
Yeah.
Try to do that sucker 4 or 5 days a week. Your arms won't tolerate it. It's the same thing, you know, and that's kind of like where, you know, when you look at BFR and its potential application, you know, if you're healthy, you're kind of just thinking about how it can sprinkle some things into your training, maybe spruce up some training. And again, maybe you just can't be training with heavier weights anymore. You know, you're just kind of there, like, welcome. You know, I'm going to be 40 in a couple of years, guys. Like, I'm also on that same bandwagon where I'm like, keep the tread on the tire. Mm-hmm. You know, like, don't wear it out. Be smart. And then, if you're injured, it's a tool that I think, with safety bearing in mind, is excellent. I've rehabbed a very fit person who's gotten injured with what I thought was, if not a faster return to function, an overall improved return to function in maybe the same relative time. But that individual expressing lower levels of just resting pain, better quality of life. And I think the process of applying it in rehab, because there's always the educational piece, kind of connects things for patients in a really different way. They kind of look at their body differently after that. I've had a number of patients tell me, like, you know, just you explaining BFR to me and me trying it and feeling what it does has really kind of made me think a little bit differently about what I want to do now, you know, when I go back to exercise. And I've had a number of patients discharge to purchasing their own cuffs, you know, and just staying in contact with me throughout the years. And, you know, having definitely a point of stopping and not returning, you know, just saying, like, where are your cuffs? Oh, they're in the closet now. But where are you at? Oh, man, I'm back out doing the things I like to do, you know, or I found some consistency, you know, and I'm able to maintain what I'm doing. And I think that ultimately in medicine is like, oh, all right, I taught this person how to fish in their pond. Like, congratulations, I did my job, you know. So yeah, it's a cool tool with application. Definitely, we need more research in it, I think, in general. And I think that's where, again, it's always going to be all over the place because we're just all a little bit different. So I think we should always kind of look at, you know, the healthy studies, the mechanistic studies as kind of a basis. And then when you look at, you know, injured individuals, they might not be able to, like, fall into that research protocol. And that's why when you ask me, like, do I veer off of it? All the time, man. All the time. I try to find what they're capable of doing with the subjective feedback of them feeling fatigue. You know, so if they're like, like my quad's burning, and I'm like, okay, they got 20 in. They didn't get 30, but they got 20, and they're saying it's burning. I probably want good buy-in, and I don't want to create too much delayed onset muscle soreness. So I may say, you know what, if it's the first session, go ahead, let's take that 30-second rest, and then let's move on and see where we get to, and build them up over time, you know? But you just have to be like that in medicine. You know, it's such a tailored process. At least I try to approach it that way, because you make somebody do that full research protocol in rehab, and watch how quick they don't come back. Watch how quick they just like, nope, that was too much for me. That was too painful. And that's where like you have to factor in training age. You know, how long have they been training for? Do they have any training experience? Have they ever done anything like a periodized model, progressive model? And then, you know, you build from there, you go from there. I mean, this is the art of medicine. Yeah. You know, this is the art of knowing all this stuff and just figuring out how to bake a cake, you know, at the end of the day.
No, I mean, we couldn't agree more. I mean, and you know, what I've enjoyed about this episode is that, again, we've talked a lot about the data, and Darsh and I talk about this all the time. Everybody who's come on is you can allow the data to kind of inform your practices, but not dictate your practices, right? And that's kind of what you're talking about. You're talking about individualizing the approach to the person in front of you, and that's absolutely awesome. I do want to ask, though, look, in the event, the example that you gave, let's say somebody was able to knock out 30, 15, 15, 15, no problems. Would you rather increase the pressure if you haven't already maxed it out versus increase the load? So what do you reach for first?
So the training pressures for the upper extremity are generally in the research, about 50% of the occlusion pressure, the arterial occlusion pressure.
Okay. But that's the upper end though, right?
That's the upper end, right. Yeah. I've started people down at freaking 20, dude, just to get them comfortable. You know, little old Mary, who's like 60 something years old, who, you know, is right now in a scenario that she is like absolutely contraindicated, you know, to do any sort of like grasping or anything, you know, or shoulder. I might have her just do some gentle little elbow things if she rules out that she's safe to do it with, you know. But yeah, you may start lower and then, you know, factor your way up there. For the lower extremities, it's generally going to be, you know, the higher end is 80%. You don't do exercise above that generally. Has there been? Yes. There has been like semi-professional rugby players that trained at like 100% occlusion and got some amazing freaking numbers in all the stuff they were measuring. But yeah, I've tried that. Yeah, it sucks. That's horrible. That feels, it's really like, yeah, no, don't do it. Sit like you're doing box squats, and yeah, it's terrible. But the pressures in the limb, I would say this: if you're healthy and you're getting started, and you've got your pressure, you've got your numbers, and you know them, okay? I would say, realistically, for the legs, start at around 60. For the lower extremities, for the upper extremities, start at around 40. Complete the protocol at that weight. If you can complete the protocol, bring the pressure up, then another value. For the arms, just go right for 50. For the legs, go to 70. Again, complete another full protocol. Awesome. Because what do you generally see in a periodization model? You generally see, first, you need to have an adaptation to repetitions, right? It's almost like you need to first be able to get the strength high enough that they can perform enough repetitions to stimulate something. And then you can load on the strength. And then you deload, and then you do it again. And then again, you make those little pursuits, you know, get the endurance, then go for the strength, then deload, help the joints, and yada, yada, yada. That's kind of like a certain model that you can use. I use kind of the similar thing in BFR. You know, start at lower pressure, get the weight where it needs to be, complete the protocol, the pressure adjusts. Once the pressure's up there, by that time, you're ready to start adjusting now the weight. Now you're ready to start going, well, your original weight is not your original weight anymore. So it's time to go up. Then you progress the weight, right? Or let's say if it's cardio, lower pressure, complete the time duration. Complete 10 minutes, you know, complete 15 minutes, complete 20 minutes, and then go up on the pressure. So I would say like low pressure, complete 10 minutes, got it. Up the pressure, complete 10 minutes, excellent. Lower the pressure, go to 20 minutes. Then bring the pressure back up, complete 20 minutes. You know, so that way you're kind of also helping, you're just thinking about physiologically what you're doing to your body. At least that's how I think about it. There's not studies on this. I'm just trying to be like the extra little, you know, thought of like, I'm about to go for longer. maybe I might want to just give myself a small, easing point to break into this, and then make the logical progression. And you can discuss that any way you want. That's just one person's opinion, on maybe how to do it. I'm just always thinking about safety. I've had a couple of things happen in my clinical experience that like earth-shattering changed my perspective on, just safety. Always be thinking about safety. It's a bad day when something goes wrong. When you have to write an incident report, it's a bad day. And they've never been situations where, I was held ever like responsible for being the person who did something wrong. It's been in scenarios where they're like, it's completely out of your control and something just happens. It just shakes you. It's like, damn, you got to be really always on your ball. So yeah, if you're going to do this, take kind of those approaches. There was a point in time that I wrote some of these protocols down and had them in a book, because again, the conversation can be a little lengthy, because it's like a whole new world. You're like, that's why literally we've got weight training, and now we have a whole column which basically says weight training with BFR, because there's a whole other area to think about. So you just got to be a little bit more conscientious about what you're doing, and why you're doing it. And a lot of times people go, oh, it's just too much, the hell with it, I'm just not going to do it. And I go, that's cool. To each is their own, But if you're on that other end, because I've had some awesome top athletes make some big headway with it, where again, the longer you train for, those adaptations are harder to get at. So sometimes having that little extra stimulus, metabolically speaking, without the expense of more joint loading, without the expense of more tendon stress because of the higher weights or torques needed, hey, that might be beneficial, under certain training conditions. And this is, you factor all those things. And so, I've used it in CrossFit, swimming, running, football, basketball, soccer, a lot in soccer, and in general weightlifting, and they've always been considerate to where the person is in their training program. Were they in a scenario where they needed to decondition, right? Realistically, were they in a scenario where they needed to just have higher metabolic stress, like, right, to achieve, higher heart rates, higher lactate training, higher peak performance training. And then just like kind of measure those two, like, where am I at with that person? Use it with a number of police officers, firefighters, and military, like pre-screen, so that if they have like a fitness test, excellent freaking tool, man. You try putting those on your legs and like drag a shuttle, put those on your legs and get on a Jacob's ladder, put those on your legs and get on, a freaking Versa climber.
Yeah. Or
on an aerodyne. Whoa, man, aerodynes are ridiculous. And just see what happens. Like even short, like four weeks training, 2-3 days a week doing it. Man, some drastic changes.
Yeah, no, I think what's funny, you're talking about the lengthy conversation. For our audiences, we had set a timer because we had to.
We're over.
We've shattered that but it goes back to the point that you just made is, this is a conversation that you can't kind of confine it to limits of an hour and stuff, because again, there's so much more that I know wanted to touch on, but we just unfortunately didn't have the time. But just to kind of recap all the things that you mentioned is, again, one thing that I hope people take away, that this is an awesome tool that's well supported by the evidence. It has widespread utility, but it's just another tool in the tool belt. And going back to this pendulum that we talk about, it does not replace good basic strength and conditioning principles. I know you touched on that earlier. And of course, you talked about rule number 1 is do no harm. So safety first. I think you've only said that about 87 times in the last 2 episodes. So yeah. I want to bring that home as well.
Tattoo I should put somewhere on me.
Yeah, absolutely. But Mario, listen, man, before we let you go, I do want to know what the next steps for you are. What are you excited about? What you got coming on the pipeline for you? Anything, we'd love to hear that.
Yeah. So again, going to be taking a stab at just making some connections with some potential virtual conferences that have, open opportunities for speakers on the topic of BFR, likely in kind of a couple of those areas, maybe potentially in orthopedic rehab, or it could even be in cardiovascular. And that's just because I just finished the whole entire 8 weeks of, advanced cardiovascular, and my brain is like oozing things out of my head. So I might as well like put it to use. But also chronic pain. There's an excellent opportunity that I've seen again, respectively understanding how motor unit recruitment augments, pain experiences, modulates, vagal response to the heart. There's a lot of things that we can go into with it. So that's kind of one area. And I think there may be a webinar at some point coming up from MatUp. They've kind of asked me and invited me to see if I want to get on that. And if you guys just, Google MatUp, I think they do have an English site, so you can kind of see some stuff there. And we're kind of in discussion what that webinar may be. And it's probably going to be just focused on something. So obviously there'll be slides and pictures, and Mario will have to follow a script. So, we won't jump all over the place. But yeah, that's going to be it predominantly. I'll probably be doing some more stuff on Instagram shortly coming up, just trying to kind of figure out life right now. It's a lot of extra responsibility. Yeah. And that's kind of where you guys will probably, if anybody wants to just find more, just, check out Instagram at Lifters Clinic. That's probably where I will just be dropping some things over time. And yeah, again, if you want to pick up some cuffs, feel free to check out H+, great company, good builds, affordable. And you can use that code Mario10. That'll give you a discount off of that. So you can just get started. And maybe I'll do a training manual one day.
Cool.
I'm always like, should I go back that way? And things are kind of good now for me to try, so I'll just leave it there. Maybe I'll get the energy to do one.
Absolutely. And we will post all of those links in the show notes. Mario, one last question for you. But before I ask you that, I just want to say thank you so much, man. I know you're a busy guy, but taking out, a couple of hours of your time just to educate us and the audience and going into that much detail. Honestly, I mean, we all know that you're on the forefront of BFR, and me and Altamash are super excited to kind of see what's next. So the last question for you here is, how do we put the health back in healthcare? And I know you touched on this a little bit in part one.
I think it really just stems from just an understanding, like we're all in this bubble together right now, so putting health back in healthcare, I think kind of starts first with, yourself, like really applying these strategies to your own personal life, and taking them seriously, that they do affect how, it's like the saying goes, like, keep your act sharp. You need to keep your mind sharp. That's literally the point of even this podcast. And all the people you've had on this is to expand your mind. And this is such a fundamental way to do it, right? We're humans are so astute at being able to listen and use our imagination and apply these things in such a fast way that we assimilate that data. So yeah, start with you. And that means start with education and focus there. And then, always practice with, I just say, just practice with your heart in your hand, practice always being authentic, to the patients you're working with, because they also have, their own lives. And, in the end of the day, again, we are with each other right now and only now. That's it. There's no other time other than right now that you're going to be able to impact that person's life ahead of you. So, do it that way, do it responsibly, and stay up to date.
That's beautifully said. Thank you, Mario.
All right, guys.
That was an information-packed episode. I hope you guys were able to follow along, because we did get into the weeds a bit, but because it's somewhat of a novel modality in our clinical practices, it's worth truly understanding the why behind what we're doing. As always, Darsh and I are going to revisit many of these points in our lessons learned episode, and perhaps that will help elucidate the applications further for you. Meanwhile, timing couldn't be more perfect to head to financialresidency.com/weatherby for a streamlined locum tenens experience. Whether you're new to locums or a pro, Weatherby is here to get you where you want to go. Before you sign off, guys, please remember this important disclaimer that everything in this podcast is for educational purposes only. It does not constitute the practice of medicine, nor should it be construed as medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues. However, if you enjoy the show, please be sure to subscribe, review, and share with anyone who you think will gain value from this as well. Until next time, thank you for listening.